Welcome again to Favaloro Foundation University Hospital. We are now at the CAT lab number 4. On my right side, Dr. Carlos Fava, our fellow, Joaquin from Manaví in Ecuador, Christian as a technician, Nora as a nurse, Juan is the product specialist for MyVal. Behind the screen is working Hernan and Dr. Andres Rodriguez for questions from the audience. Our anesthesiologist here, Dr. Jaime, Dr. George, yes, of course, and Dr. Mucarcel as a cardiographer. So let's go with the first slide first to introduce the case. Next. So he's an 85 years old male presenting with dyspnea. He has history of hypertension, dyslipidemia, a former smoker. Also a spinal canal stenosis with some limitation for walking. It's not there, but he has a bilateral hip replacement. He is not fragile and not fertile. Next. So on the ACG, we'll see a little bit better. It's on the normal sinus rhythm with previous conduction disturbances. He has a first degree AV block with 220 as a PQ segment, the QRS with a left bundle branch block with 160 milliseconds duration. He suffered from some anemia with 32 for hematocrit and some also renal dysfunction with a urea of 70 and creatinine of 0.7. The body mass index is 37, and the echo Doppler is unveiled a severe aortic stenosis with a hypertrophy with an area of 0.8, with a gradient of 77 and 50, but Dr. Murcasel is going to show you the echo in the morning. The coronary angiography didn't show any significant lesions. Next. So this is the ACG. Probably the image is not that good, but it's just to let you know a significant conduction disturbance in this patient, and probably he is under high risk for permanent pacemaker implantation. Next, this is on the coronary angiography, a big coronary artery with a little bit abnormal takeoff, with some, diffuse irregularities, but not significant stenosis. Next. So this is the left with the calcification on the proximal segment of the LAD and the diagonal. Also some calcifications on the circ, but no significant stenosis, just a moderate stenosis in this proximal segment of this huge and large diagonal branch. But in our opinion was not significant, and the patient was not suffering from angina, so we decided not to treat. Next. So this is on the spider, epicranial, and then the spider view, where you can observe mild lesion of the ostium on the circ, but no significant stenosis. Next. And this is on caudal angulation, on AP caudal angulation. Next. So this is a CT scan evaluation done by us here at Favaloro. The ascending aorta is 36 and 34 on diameter. It's quite normal, with a significant valve calcification on this tricuspid valve, especially on the non-coronary cusp. This is important. We have discussed here in previous cases, especially when you are using self-expandable valve, because you might have in some cases difficult to know for nose retrieval. Actually, I was commenting a case on Twitter, very interesting, on the 2 or 3 days ago, and some maneuvers to rescue the nose cones when you have this difficult. But this is an important imaging that you have to observe if your plan is to use self-expandable valve. Next. So this is our measurements on diameter of 24 and 26, with a mean diameter perimeter derived perimeter of 25, with a perimeter of 78 and an area of 485 square millimeters. Next. The LVOT is quite similar on diameter. It's conical. No, it's not. Bigger than the annulus. And there is the sinus of Valsalva, which are big, 32, 33, and 30 millimeters on diameters. And once again, with calcification, especially on the free border of the non-coronary leaflet. Next. So these are the ostium heights. As you can observe, the left is at 15 millimeters and the right is also at 15. So it shouldn't be a significant problem there. You can observe on the right of the panel some calcification above the right ostium, especially on the sinotubular junction, but it's small, it's not concentric. Next. And this is the aorta. The aorta has important tortuosity, especially on descending aorta. And then there is a highly angulated annulus. As you can observe, the angulation estimated is 70 degrees, which is almost out of the indication for self-expandable valves. And this is one of the reasons why we have chosen for this case a balloon expandable valve with a deflectable catheter. Next. So this is the calcification that I already mentioned about the right ostium, calcifications of the leaflets. And this is our implanter's view. We have chosen the right caudal angulation, 3 on right, 21 on caudal. This is for right and left cusp overlap view, which is our regular, implanter's view that we are using for any valve here at Favaloro. Either for self-expandable or also for balloon expandable valves. Next. And this is the abdominal aorta where he has a dilatation and I would say an aneurysm because it's 32 and 33, but it's not too big with the thrombus on the, especially on the anterior wall of these aneurysms. This is important when you are going femoral to be careful for advancing. When you have huge aneurysm, this is not in this case, it's probably one indication for using a Landerquist to prevent any, scratching of the aneurysm and also to deal with angulations, especially at the level of the infrarenal necks. So in my humble suggestion, if we have a patient with aneurysm, it's better to go with the Landerquist instead of the Confida or Safari wire. But in this case, which is straight abdominal aorta below the renals, with this, I would say, small dilatation, I would go with the regular Confida wire. Next. This is the right iliac artery, which is quite normal. It's a big artery, not significant calcification, 10 millimeters on diameter. This is the reason why we have chosen to go with one single prograde, and then we use an additional angioceal. Next. This is the left, almost the same, a little bit more dilated at the level of the common iliac artery, but then the external artery is 8.5. Next. So in summary, it's an octogenarian patient with anemia, moderate renal dysfunction, a small abdominal aortic aneurysm, and severe aortic stenosis with STS core mortality of about 10%, a morbid mortality of 32%. So after the heart team discussion, they suggesting to proceed with TAVI. Next. So we are prepared today for a percutaneous femoral access with a balloon expandable TAVI, as I have already mentioned. Next. This is the valve that we are going to use. We have used it in some cases before. This is MyVal from India. So it's a balloon expandable valve, which is also mounted in a deflectable catheter. This has an open cells in the upper crown, which is to facilitate the coronary access, and then a PTA skirt to help for the sealing of the valve. Next. So regarding the sizing, next click. So we are in an intermediate measurement with the area of 480 and other measurements about 500, which is intermediate between the 26 and the 27.5. So we have decided, discussing with Juan, who is our product specialist, to go with the 26 because of the following estimations. Next. here, according to this estimation, if we use MyVal, this is the chart size for MyVal. If we use 400 to 80 millimeters, the 26 is going to be an oversizing of 10%. If we estimate for the S3 valve with the 26, we are be a little bit below with 7%. We should use probably 1 overfilled cc to get close to 12%. So we have discussed and decided between these two sizing measurements, and we have decided to work with the 26 plus 1 cc because we have 2 or 3 different measurements of the annulus, 480, 490, and 500. So that's why we have chosen to go a little bit higher with the 26. Next. So let's go to the lab. I will ask Dr. Mukarsel to show the echo, today's echo. Let's move the video for the echo. Stop showing the slides, and there you have the echo. You can show the measurements you have done. You can see we have normal function. Previously reported radius.
Pero ya si querés.
Radius were a little bit higher than
No, acá.
Were 165 of mean gradient, and LVOT diameter was similar as reported in the angio. So we also we can see here a short axis of the aortic valve, and calcification is predominant on the non-coronary artery cusp, as seen in.
Okay, thank you, Juan. And now we can show what we have done. So Christian is going to show the angio of the. So this is the patient with the previous hip replacement. We, as you can observe there is a significant calcification on the iliac arteries, but they are, very big. Next. So we are always on the safe path, trying to put a contralateral wire. Remember that if you don't have the chance to do this, you can put the wire below the vascular access. Next, Christian, let's go. Proxima. And or if not, you can also have a radial access for control or for testing if you have bleeding in the vascular access. This is a particular patient. He was not, this is not a tattoo. This patient received by a very good echocardiography, an evaluation before starting the procedure, an echo and also vascular echo. And he left here an arrow where I should puncture. Anyway, we did the puncture guided by angio and by echo. If you can see here the arrow with the camera. Where is my finger? So now we are going to introduce the ProGlide. Corre para tu lado, Christian. And then we are going to introduce the Python expandable sheet, which belongs to the valve. Our plan, due to this significant calcification, is to pre-dilate with a 23 millimeter balloon to prevent any, I would say, difficulties for crossing during the live transmission. So I will leave the ProGlide thread there. I will introduce the Amplats wire. Let me see. Probably too much coffee or too much venom on the Amplats. Let's see. Of course, we have put, implanted a transient pacemaker on the right ventricle because this is a high-risk patient for AV block and for needing a permanent pacemaker implantation. So this is a patient that we don't like to pace with the wire, and this pacing is gonna be kept in place for at least until tomorrow. So, okay. So the sheath is in place. I have to rotate to retrieve the dilator. Leave the unplugged wire there. So as always, I have here a suture to fix the sheath to prevent movements during the deployment. So I'm gonna fix the sheath before continuing with the procedure. Sorry. Give me something, the scissor. Okay. So remember that we have the chance to answer question. Baja la luz, Christian. Okay, I don't know if this wire is crossing. We will use it. Dame la válvula. I'm going with the pigtail. No. Okay. So we will try to cross, as always, with a regular J wire. As it is a heavily calcified valve, we might try with the unplugged catheter and a straight tip wire. Because the aorta is so angulated, it's going to be difficult to get in a good position with a pigtail for crossing. Try the unplugged, because it's too much angulation there. Pone un poquito oblicuo. Okay. I need to go to the left cusp, but it's impossible due to the angulation. You might see there a significant calcification on the non-coronary cusp. Okay, let's try with the, because we are running a little bit out. Short of time. So for the audience, of course, you can ask questions and comments. If you have chosen a similar valve or a self-expandable. Yes, Andres.
Which prosthesis can minimize the need for the pacemaker?
Well, I think here we have probably two indications for a balloon expandable valve. Dame la recta. Correcto. One is because the angulation, which is the most important thing, and second, we will try to prevent to implant a permanent pacemaker implantation, although these patients should receive an evaluation from the EP guys, because probably he already has an indication for the pacemaker. But this is the reason why probably I will choose a balloon expandable in all patients like this. But remember that here sometimes we cannot select the valve and we have to deal with the authorization from the health insurance. Pone de frente. Let's go. IP view. There we are. We have a significant calcium there. So we have to deal a little bit more than usual for crossing. I'm sorry. I didn't want to cross because, oh, sorry. In advance because we were waiting. So let me try. And the other question, Andres?
Yes, will patient require a balloon predilatation prior to valve replacement?
Well, you see, this is a heavily calcified valve. It's taking a lot of time for crossing, more than usual. So for sure, I'm gonna predilate. So probably prepare the 6 French catheter. Okay, you see there is a strange angulation for crossing, so that's why it was almost impossible to cross with a pigtail. the position of the wire. I don't like it too much, but this is the position I get. And now the patient is so tall, it's almost difficult to cross with the Amplatz catheter. You see that everything looks quite strange due to this angulation. So now I'm going to introduce the Amplatz wire to reposition this catheter and then to introduce the pigtail to be sure we are on the safe position to introduce the confida wire. You see that the aorta is almost horizontal. I'm trying to retrieve the catheter and to pull everything and then to go to the apex because I was pushing the anterior wall. I think this is important. Yeah, please, to prevent any damage of the anterior wall of the left ventricle. So that's why I don't like to cross with the Amplatz. It's something that I always try to prevent, but in this patient it was impossible or it's gonna take too much time. That's why I went to the regular Amplatz and straight wire. Our wire was not a hydrophilic. I don't like the hydrophilic wire for crossing, probably because I am too old. I prefer regular wires. So now you see we have some difficult for crossing with the pigtail. And once again, we are near. And now we are in a better position with the better angulation of the pigtail. So I think this is the area where I would like to be with the confida wire. So let's go with the 6 French pigtail. One is prepared in the valve. So he has to wash and to crimp. So we will check the gradient, which looks really high. Inside the ventricle, we have 220 or something like this. We are going to the working position. And now we don't have to hurry because we have plenty of time. We are going to flash to go for 0. Check the gradient. One thing which is important, we have already checked, is as always we discussed about it, is not having pericardial effusion before starting the procedure. So this is the gradient. Here we have close to 80 or something like this as a peak gradient. So we have prepared a balloon. This is the Python balloon. No, sorry, the Mammoth balloon. The Python is the sheath. So it's a semi-compliant balloon, 40 millimeter in length. 40, is okay? Okay, so now we are going to introduce the confida wire. We have already checked the pacemaker. Patient is stable under conscious sedation. Dr. Jaime and Dr. Jorge are working on that. Yes, and before crossing with the, thank you, Christian. Before crossing, we are on the working projection. Before deploying the wire, I will try to check if we are in a good position here for overlapping. As you can see, the projection looks like regular, déjala que se vea mejor. Regular coplanar view. Let's check if we can correct this. Let's go less caudal, menos caudal y más derecha. Let's check if we can find a better one. Menos caudal. Let's check there. No, it's worse. Más derecha, mucho más derecha. The other solution would be to introduce a second catheter, but no, más caudal, mucho más caudal. Más. So I think this is one of the problems where you have such an angulation. Let's see here with film. Oh, no. So I don't want to recross the valve. So let's take some time here. Let's retirarle todo lo caudal. So we will try to manage with the calcium. Anda craneal. Más. No, it's very difficult to find a good position. Anda AP. A ver. Okay. Ahí. Y más derecha. No. A ver. So hopeful. Let's go to. If not, we will try to find a good coplanar view and to work in a coplanar view. Let's see here. Un poquito más oblicua. Here. Okay. So here, to be honest, we have an overlapping of none and right coronary cusp. But in my opinion, it's a better alignment than all the others. Let's go, salva eso y move to, a la oblicua derecha, bien derecha. No, here is impossible. Not at all. Let's go to the left. Vamos a la izquierda.
No, el anterior.
Juan, do you agree to work in this left projection? Well, this is something unexpected, but I think here we are almost acceptable aligned. Acceptable. To be honest, I don't like too much. Carlos, leave the wire exactly in the apex. Very challenging anatomy. So let's go with this. People, vamos a ir a 180. No tires de la guía, déjala venir.
No.
You can see such an angulation. Teneme la guía. We have difficult for crossing. Now we are okay. So I think this is a good demonstration that predilatation was necessary here. So 180. Okay, let's go. Sí, desinflar. Plate. Bajar el marcapaso a 70. Okay. Esperemos que se recupere un poco. Let's recover him. Probably we might need a second dilatation. What do you think?
Yes.
Let me check about the. Oh no, we have too much aortic insufficiency. Okay, let's go with the valve. No, dilatamos el intro. Give me the dilator for the introducer. Okay. Keep the wire there, Carlos.
Yes.
Jaime, ¿le podemos subir la presión? Necesitamos que le suban la presión. Vamos a dilatar la ilíaca. Dale un bolo de EPI. Teneme el introductor acá.
Sí.
I think the aortic insufficiency is not well tolerated, so that's why not another predilatation. So let's go, the valve. Tenés buena vía ahí, si no me das a mí un toque.
26, 23 nominal más 1.
Ok,
Chequear posición antes de salir del intro, por favor.
ok. This valve, we don't have to... Mostrarme más abajo el introductor. We don't have to load it. No, más arriba, más arriba. There.
Ahí.
Más abajo. Ahí está bien. Valve is in correct position before getting out of the sheath. Let's move up. Okay. Now I'm gonna rotate the handle to facilitate to work all this very challenging anatomy. We are going okay so far. Hopefully we continue okay. Let's see. Boom. Okay, so I did it on purpose. I would rather go there a little bit lower. Test. A little bit lower because we are too angulated. It's not easy to keep the position. So probably. No. So it's jumping due to the calcium. And the angulation, any movement is too much. Yes, okay. I think we are okay. We are okay. What do you think? Juan, do you like it?
Más arriba.
Mm-hmm.
No, está bien ahí.
Okay. Okay. 180. Test. We move a little bit up. Okay. Let's go. Okay. Dos. Plate. 70.
70.
Okay, the valve is stable. Position, I think is okay. Bajar el pacing a 60. Dame la wire, the amplats. We are recovering. Once again, very challenging anatomy. There is some flaring of the valve up the annulus, above the annulus. Let me check here.
Bien, dejo.
Y recién ahora
Ahora va a ser controles. Copia fiel,
Oh, beautiful.
Gusta mucho más la balón expandible que la automática.
Better than expected, probably.
Bueno, cambiamos.
Okay, I like it. I think the position is okay. On the non and right coronary cuspid, where we have the overlapping, we are probably at 3 to 4, and probably 6 to 7 on the left. Diastolic pressure, you can show the hemodynamics, and we can put AP view so that Dr. Mokersel can check the echo. I will pull the delivery set. Wire is inducing extrasystoles. Oh, the wires. Give me the pigtail. Wait a minute, Juan. Patient is also very long patient. Okay. Okay, give me the pigtail and pone AP, AP view, so Dr. Mokersel can control. I think we don't have too much to do here, but anyway, we'll like to check it before. I will retrieve the wire. Give me a second, because I don't like the position of the wire. Okay.
Okay.
We have some very sheet bleeding here. Take the gradient. You know, he's responding very well to some epinephrine. Now the blood pressure is 200. Diastolic is 70. Let's go down. Let's check here. Oh, so this is his arm rhythm. He is on the, I would say, normal sinus with the left bundle branch block, almost the same that it was before. The pacemaker is disconnected. Now again it's connected, but put it on 50, el marcapaso 50. So,
okay, so everything looks very good here. Gradients are,
yeah. Okay. Will you share the echo? Okay, perfect. Keep doing.
Okay. So gradients are 13 and almost 6 of mean gradient. LV function is normal. We have no leaks at all. And no effusion.
So I think that the outcome is really good. So the decision of going probably 1 cc more was okay. And finally, I think the orientation we got with this overlapping, but exactly the opposite, was acceptable for positioning. So you can see on the right of the panel, sorry for the Dr. Mokersel hands, you can see the orientation of the valve. It's exactly parallel with the vertebrae. So it's showing that the angulation was exactly the angulation we estimated during the CT scan. Let me be here. So I think we don't need to do an additional angiogram because the patient has renal dysfunction. So I think I lost in the position with the pigtail. It's there. So I think the procedure is done. Let me check if we can close here. We have some, bleeding. We would inflate the un balón de 9. Buscate, Nora. A 9mm balloon, and we will introduce the 8 French angioseal. Tráelo. And then Carlos is gonna hold the groin for some time while I am going to work in the other lab with our congenital heart disease specialist. Give me the light, people. So, baja la camilla. ¿Podemos revertir heparina primero? Por completo. Sí. Give me the dilator. So before retrieving this expandable sheath, I always introduce the dilator to prevent additional damage of the femoral artery. So we will introduce this, and then we will put the 6 French. Right? No habrás cortado el prolay, ¿no? No. Ok. Ok. Sí, porque yo le hice una cosa acá.
2 puntos.
Espera. Ok. Take your time. Take your hand out. I did a surgical procedure there. So after this, I will prepare while heparin is reverting. Okay, contener la intro, Carlitos. Tiene bien, ¿eh?
Sí.
Okay, give me a 6 French sheet. So it's a big hole in a big artery in a patient with hypertension. So let me close. We still have some bleeding, but not that bad. Release. So you can see that it's almost okay, but I would really like to use the angiosil also. Give me the angiosil.
No.
Sí, no fuimos. Bueno, ahora lo testeamos.
Ujú.
Lo ponemos ahora. So let's tell me the time, people. People, decime el tiempo. El tiempo, ¿qué hora es? Okay, we still have 5 minutes here, and then I'm gonna move. So I would ask Andres if he has some additional question from the audience. So let's give me el mamario. So we are closing everything here. I know that Samit take 10 minutes from us because he knew it in advance that we are going to finish earlier. Give me there. So we are one final. Okay. One final, and we will take a shot to be sure we don't have bleeding. And then Carlos is going to finish with an additional angiosil on the left side. ¿Qué hora? Time? ¿Qué hora es? Mostrame abajo.
-5.
Okay. Espera, Pipo. Ahora. Okay. So we are going to keep this wire on the right ventricle for at least 24 hours until tomorrow morning. Tomorrow morning, we will decide what to do. We will discuss with our EP guys whether these patients need a pacing or no. Pone oblicuo para mi lado. Here. Acá. Saca, Pipo, para la pierna.
Abajo.
Soltame la camilla. Ahí. Okay. Okay. Excellent. This is the bladder, no it's not the iliac artery. Okay. Okay. We are finished. We retrieve the wire, and Carlitos is gonna finish. So thank you so much. I think it was a very nice case. You can see. We can leave you with the echo imaging where you see how circular the valve is. Can you show the echo image? Perfect. You see a very nice view of the very, I would say, good position of the valve in such a calcified 3-leaflet valve. So see you in the next room in a few minutes.
Okay.